I'm getting a phone call from Kennedy, Terry Kennedy. Do I need to answer that? Okay.
She does. Okay, making sure she got on. Okay.
You may begin.
Okay, thank you everybody for coming this cold, brisk morning. The good thing we're inside, we're not out there in the cold. We're gonna call the Health and Human Development Committee to order. And on April the 4th at, what is it, 9:05 a.m. Madam Clerk, would you call the roll call, please?
Alderman Vollmer,
Present.
Alderwoman Tyus, Alderwoman Schweitzer,
Present.
Alderwoman Sanye,
Present.
Chair Boyd,
Present.
Alderwoman Tyus. We have 4 present. We have a quorum.
Thank you. And so I ask for the approval of minutes from our last meeting. I don't have the date in front of me. I'm sorry.
For March 28th, 2024.
So
Okay,
moved.
second.
Previous roll.
All righty.
I don't, maybe you voted yet.
Wait, I know.
Objection.
I have a little fun. Gotta see if everybody's awake.
Awake.
Alderman Vollmer,
Aye.
Alderwoman Tyus, Alderwoman Schweitzer,
Aye.
Alderwoman Sanye,
Aye.
Chair Boyd,
Aye.
Alderwoman Tyus. We have 4 aye votes.
All righty. Thank you so much. And so we don't have any board bills to review. We are having a presentation today. I'm honored to have the health department come in. From the health department, from the health committee, the concern is we have an increase in HIV, and it's my understanding in women. And I want to say California, they had a measles outbreak. And so with the spring break, I was just concerned that kids will go down there, have a good time, come back, and we wind up with an outbreak in St. Louis. So we'll have Susan Alexander from the health department to kind of explain to us and give us some information that could help us to understand this whole process and how the health department is addressing it.
Good morning, and thank you so much for the invitation, Chair Boyd. May I share my screen?
Yes.
It's going to take me just a sec to set it up. All right, can everybody see?
Yes.
Fantastic. Again, my name is Suzanne Alexander. I am the Bureau Chief for Communicable Disease, which oversees all of the infectious disease in the city of St. Louis, which includes your normal run-of-the-mill airborne, respiratory, enteric, tick-borne, and other vectors, as well as HIV and STI, tuberculosis, and as you may remember, outbreaks and pandemics of any sort. So it is a big job, and I'm honored to be able to do it. We're going to talk about measles first because I'd like to alleviate some concerns about that, but I do want to present the picture. My goal here is not just to give you an overview of what we are learning in the city, what we're monitoring, but also what we're currently doing behind the scenes in order to prepare for any information that needs to be provided to our city neighbors and to you all, the Board of Aldermen, as well as the Mayor's office. So I chose to go with measles first, if that's okay with everybody. We know that measles is a virus and that it is incredibly infectious. What most people don't know is it is potentially life-threatening. So from 1952 to 1963, there was an average about 500 people dying from measles annually, but just as importantly, about 1,000 people developed chronic disability from acute encephalitis, which causes neurological damage. So from 1963 on, the vaccination program had been so successful that in 2000, we declared measles eliminated in the United States. So normally when we have cases in the USA, it's usually from unvaccinated Americans who travel to other countries and return with no idea that they're sick. And because the virus is incredibly infectious, it only takes one case to cause an outbreak. And even in previously healthy people, measles can cause hospitalization or death. So what is going on with measles? Well, the big problem is that measles can be contagious before symptoms appear. It typically incubates or starts building up and making copies of itself for about 10 days past the initial exposure. And then you're actually contagious from about 4 days before symptoms start, like the rash and the fever, until about 4 days afterward. So unfortunately, because it's a virus and because it's so infectious, there's no real specific antiviral therapy for measles. So we provide medical care to relieve the symptoms and to address complications like opportunistic bacterial infections such as pneumonia or the encephalitis that I mentioned earlier. So per the CDC, up to about 9 out of 10 people who may be susceptible to measles, and we'll talk about that in a second, will develop measles after a close contact with the measles patient. About 1 out of every 1,000 of those measles cases will develop acute encephalitis, which often results in permanent brain damage. And 1 to 3 out of every 1,000 children who become infected with measles will die from respiratory and neurological complications. And let me know if I'm going through the slides too quickly. So what is going on? At our most recent briefing with the CDC, which just happened this week, there are 97 cases across 18 jurisdictions. And I've got the numbers up here, so I'll let you go ahead and read through those. 56% of the cases in the United States right now have been hospitalized for isolation or management of complications. 34 of the hospitalized patients were under 5 years old. A few more statistics. 60% of the cases were unvaccinated, which includes 50 children under the age of 5, which means that 68% of the children under 5 were hospitalized. What are we going to do? Well, the best way to take care of this is to prevent measles through vaccination, prevent it from ever happening. The good news is that we have an estimated 91.3% of kindergartners in Missouri who've received their MMR vaccines for the 22 to 23 school year. We communicate with our schools via listserv, site visits, phone calls, meetings. I personally am on call 24/7 with DHSS if I need to do any contact tracing or case investigation. And you all may recall that last year we had a case in St. Charles. Well, I contacted every single person who had been exposed to the person in St. Charles, and I'm pleased to say that we did not have anyone who was unvaccinated and were not at risk. We also have held training for our communicable disease investigators. We held that on March 6th, and then we had a CDC all agency training on March 29th. Here are the phone numbers for finding out where you can get a vaccination, finding out when you received your last vaccination in case you're concerned about whether your vaccine needs to be updated, which is something we encourage everyone to speak about with their medical provider. We've also created health advisory alerts, which we've sent out on social media. We have a partnership with a local online radio. So we're on the internet. Dr. Madi has talked about it online. And we also have done interviews with local papers as well as national papers. So this is getting the information out to the public and ensuring that our neighbors know where to get vaccines is the most important part of our response to the measles concern. Before I go into HIV and AIDS, does anyone have any questions about the measles?
Madam Clerk, could you call to ask any committee people if they have any questions at this time?
You want me to ask the committee people if they needed or wanted to ask questions or make
Yes, ma'am.
comments?
Yes, ma'am.
Okay. Chair, committee people, all the persons? Do you
All right, no
want to
questions.
have any questions or comment?
No
Chair
questions or comments from me, no.
I think that, first of all, thank you for coming and presenting to us. That's really interesting about the measles. The 91% in Missouri stood out to me. That felt like a good number, but how do we compare to other states? Is it lower or higher than what other states see in there?
You know, that's a really good question. I focused more on the city of St. Louis, and we have had a really good response from all of our charter schools, all of our private schools, and of course, the SLPS school district. So, but I am happy to get that information back to you.
Thank you. It's more just a curiosity. I'm always interested in how our state stacks up. When you're talking about things like health and So, thanks for the presentation. I look forward to the next part of it.
Thank you.
I don't have
I-
any questions.
Okay, and so I have a question. So how are we, I hear that you saying that you on calls constantly, Susan, with the St. Louis Public Schools and other agencies in regards to this measles epidemic. So how are we educating the parents? Because I'm like Alderwoman Schweitzer, so we're at 91%. So how can we improve our numbers in regards to education and empowering those parents?
Absolutely. That is a powerful question, Chair, and it is an important question. Education is incredibly important, but what I have found through my experience with talking about the COVID-19 vaccine with my neighbors is that you have to be prepared to allow people to digest the information they're getting from the health department compared to what they're hearing online, comparing to what they're hearing from folks who don't think that vaccines are healthy for their children. We try to walk a fine line between addressing misinformation and respecting someone's choices and intelligence. I never want to put somebody in the position of feeling defensive when so I never say, well, actually, this is what could happen. Occasionally I will bring up anecdotes, and I encourage all of you to, if you know of anybody who has been through measles. I received the measles vaccine at 12 months, which was a week before there was an outbreak in Detroit, where I'm from. And I had such a high fever that my mother gave me ice baths. The little girl down the street, unfortunately, had not been vaccinated at all. And she ended up with permanent neurological damage. She unfortunately was robbed of her life, essentially, that she had before the measles happened. So I have to stay away from sharing that with people because I don't want them to feel like I'm trying to scare them in to get a vaccine. What we try to do is put out messaging that is true, frank, easily understood, and supportive. What the city could do is to share that messaging wherever you go. One of the things I do love is being able to be out in the community, having people see who we are, know that we are their neighbors, and we care passionately about public health in the city, because then that establishes rapport, I hope, and a little bit more trust. And it is very important to everyone at the Department of Health that we become and/or remain the most trusted source of information about public health.
Mhm. Okay, that makes sense, because as we all know, it's some people that are skeptical of health in general, and a lot of people think it's a conspiracy theory. I mean, we learned that through the whole COVID thing. And so then a lot of African Americans have a justified reason because of the history on what they were dealt and how they were handled. So to the point where they were injected with germs to make them guinea pigs. And so that's why a lot of people are real skeptical of that.
And I respect that. I would feel
Yeah.
the exact same way. And so what I try to do is ask questions. How do you feel about your relationship with us? Because we want to be separate from the past. We want to respect the trauma of the past, because I don't blame a single person who has been part of a demographic mistreated by the United States government, by the United States itself. And I am a firm believer that we are not going to reach equity until we have health equity. And health equity depends on a lot of things. It depends on economic opportunity. It depends on availability of resources, and it depends on respect. So we do our part. We will continue to do our part. I think that I let my team with lived experience, especially in the Black communities of St. Louis, be the ambassadors, because they can speak to that shared experience, right? And I think it is both more respectful of their concerns and also more effective and impactful to hear from peers how they overcame their reluctance to work with public health, to work with the government, and to take a more critical look at what's being offered.
I appreciate it. Thank you.
My pleasure.
So, on that note, you want to start with something that we really hate to have to bring up, but it's a reality, the HIV epidemic.
Absolutely. And so I want to give you kind of a little bit of history about the HIV epidemic. I'll go into it a little bit more in the next few slides, but a lot of times you talk about HIV and AIDS and don't really talk about the difference. We have two cohorts here. We've got people who have received a positive diagnosis of HIV, and then we have people who, through either a failure of the system or through a failure of the immune system, the person's individual immune systems, have come to be diagnosed with AIDS, which is the active form of HIV. The goal with ending the HIV epidemic is to ensure that people who are living with HIV have their virus levels. And remember how I mentioned with measles that there's that incubation period where the virus makes copies of itself. That's how you become actively infected. If we can stop the virus from reaching a certain what we call viral load, meaning it can't make so many copies that can be transmitted to other people, then we have what we refer to as U equals U, which means if we can't detect the number of virus copies in your body, they are undetectable. That means that it's untransmissible. So there's three prongs we're working with. We're trying to keep people who are living with HIV from having a viral load that is high enough to be passed to other people. We are trying to keep people who may have reasons through intimate relationships or through familial relationships from becoming infected with HIV. And we're also trying to extend the lives and improve the quality of life for folks who are in that active immune deficiency syndrome stage. So with that being said, we do have a heavy burden of HIV/AIDS. And Chair, I'm sorry I didn't break out the numbers for women in particular. I will say this, it is rare to find someone who may be more susceptible to HIV who is not also more susceptible to STIs. And, you know, my other passion is congenital syphilis and how we need to address transmission altogether. So yes, we are seeing a rise in women, particularly in Black heterosexual women who would never have believed that they would be susceptible because everyone considers HIV to be a gay thing, for lack of better words, mostly for men who have sex with other men. And that's simply not true. And that messaging is difficult to get across because particularly when Black women bear the brunt of oppression in our country and even in our city. And so disease is seen as a stigma. Yes, it is shameful. You're not clean. And so it is difficult to provide the messages of support without implicating or insinuating that someone may not be a good person simply because they unfortunately became infected. So I will, if you like, provide those numbers to you separately via email.
Okay.
Happy to do so. Let me make just a real quick note. And if you don't mind, I'll also send along information about women with STIs. So we are noticing that some of the numbers are trending down, other numbers are trending up. STIs are trending down in age, whereas HIV is trending up in age. And so I mentioned that not because I have epidemiological reasons for it, but I wanted to give you that little bit to let you know at least what we're looking at in terms of the age range. So the good news is we have seen a decrease across the United States in general for new diagnoses, which means that particularly in areas where public health is well funded and there are strong and energetic initiatives to improve the numbers for folks living with HIV, we're seeing the actual effects. We are seeing improvement. And, you know, there were an estimated 1.2 million people living with it. There were 31,000 new HIV diagnoses. So it's not as if these numbers are not still pretty large and heavy. But in contrast with other STIs that have federally funded programs behind them, the decrease is good to see. In Missouri, the state itself, we did see a drop between, and this says 21. I thought it was 2017, but what I will point out is that Missouri is number 34 in the United States for new cases. And in St. Louis, we actually did see a decrease in cases as well, from 107 to 72. 2021 happens to be when we also launched a new federal program called Ending the HIV Epidemic. And it is also when we started putting together resources for what's called PrEP. PrEP is pre-exposure prophylaxis, which means there is medication out there that we can provide to people who may have reasons to suspect that they could come into contact with HIV to prevent them from contracting the illness, because the virus can never actually get a foothold on their immune system because they're getting this medication that bolsters their immune system against HIV. So it is good to see that the numbers have gone down. It is unfortunate that our case rates, which is the number of people per 100,000 people who actually have HIV, it's still larger than the national. And I'll tell you why, or give you an example. Missouri had a rate of 8.86 per 100,000 altogether. In 22, that decreased to 8.1%. In the city of St. Louis in 2021, we had 35.9 cases per 100,000. So that's about 4 times worse than the state rate and more than 3 times the national rate. In 2022, even though we had a decrease of 72 new cases, it's still 24.2 per 100,000. And remember, I said the case rate for Missouri as a whole was 8.1 per 100,000. So we're still about 3 times worse than the statewide rate for that year. Take into account, a lot of this is because we have a denser population. And so when you compare rates per 100,000, it can be difficult to actually understand what those numbers mean, which is why I included the new case information. Because of the way that data is released, sorry about that, because of the way that data is released by the Department of Health and Senior Services and the way it is funneled through the CDC, we don't actually get numbers as quickly as you or I would like. And that is because they are carefully assessed, cleaned, and released. And so we just received the 2022 data. We will not get the 2023 data until 2025. So what we do locally is we take a look at how we've ramped up our efforts, and we try to match those efforts up with what we're seeing. Are we seeing more people getting infected in these areas? Well, we need to focus on these areas. And so we try to work micro environmentally to ensure that we're reaching the people that we need to reach. And we're seeing a lot more support for this at the national level, which is good because that's where we get our funding from. We receive pass-through funding from the CDC, from HRSA, and now from other agencies who joined this national HIV/AIDS strategy. rather than from the state itself. And so the programs are able to sort of cross-collaborate a little bit more. Our goal is to reduce new HIV infections in the United States by 75%. And remember what I said, an HIV infection is when a virus is able to get a foothold in somebody else's immune system. So again, that's why PrEP is so important, and that's why testing is so important. If we can test people before they're able to pass on the infection, and we're able to get them on the medications and into case management that help lower their viral load, then we can meet those numbers. So I am pleased, proud, and honored to inform you all that we are the regional lead agency. And for the Ryan White Foundation, which is focused on people who are already living with HIV, and for the HIV prevention team. And we are in charge of making sure that the perimeter counties around us, including St. Louis County, Warren, Lincoln, et cetera, have the resources they need as best we can to reduce the amount of infection and contagion in their counties as well. So the way we do this is to work with the folks who are doing the work. And the folks who are doing the work are the community-based organizations, and that we fund, and that we are hoping to rebuild a coalition with that fell by the wayside thanks to the pandemic, when we saw, lack of testing because people weren't able to get out to get tested. So we're bouncing back, and we're in an era of rebuilding, going with evidence-based programming, taking a more scientific approach to outreach, making sure that we're meeting the right people. And I am proud to say that we are doing just that. We are trying to make HIV test kits more convenient for people to pick up. So we have an online program called the Take Me Home program, and residents can scan a QR code at any of our events, and or they can go to the healthstopstl.com website and order a kit through our community partner, NASDAQ. And NASDAQ will send out the kit to them free of charge. We will provide them at-home test kits when we have them free of charge. And we also on our website can have folks schedule testing appointments right there. And by searching through our website, you'll be able to see that we have other resources, not just sexual health resources, but social support and links to the other organizations. So if you're not willing to work with the health department, we understand, but maybe you'll be willing to work with Williams and Associates or Novus Health or Vivint Health. And we encourage those relationships because it doesn't matter to us as much who you see, but that you are seen. So we also have free condoms that and we have a condom distribution program where we go out, and currently we have 83 partner sites. We're working on expanding those sites out into the perimeter counties because we know that folks travel in and out of the city to enjoy the social life here. And so we know that we have to look beyond the city of St. Louis to halt this epidemic. We are focusing right now on outreach because you can't meet people unless you meet them where they are. And so I am so excited to say that we have returned to some of our regular programming, probation and parole. We do regular testing clinics at St. Louis University and at Harris Stowe. And for the first time since the pandemic this year, thanks to being able to restaff our section, our program for HIV prevention, we have held an average of 4 additional events per month since the start of this year. And when you take into account that this is, when we say 4 additional events, these are on weekends. These are in the evenings. And so we've finally got enough people to staff these events and to provide the testing and answer the questions. So it's very exciting. We are always willing to add additional outreach opportunities as requested by the community or by you all, by anybody really. And we do have a plan for expanding our reach, moving beyond the current geographical area we're in out to the further reaches of the city and beyond with our mobile testing unit. So And one thing I'm really proud of is that we have worked hard and will continue to work hard to destigmatize sexual health by having the PrEP Week, annual PrEP Week. We're planning to do it again in October 2024, the last full week in October. And we also are working on making condom distribution more interesting, exciting, and appealing to folks of every age. So that's all I've got. Do we have any questions from this one?
Alderman,
No questions. I believe you've had a very copious amount of information there. You've covered most everything. Thank you very much.
Thank you. I could give more.
Alderwoman Schweitzer.
Thank you so much. That was really interesting as well. One of the things I noted that you talked about was working with clinics in the city to have your products available or the products available for testing. And one of the things we talk about a lot is the difference between the county health department and the city health department is the clinic piece. Do you feel like that relationship is working with clinics in the city of St. Louis and the way the health department does that work is best serving the people at this time, or I just love your thoughts on that in general.
Well, my thoughts about that in general, let's see. So I'm just a bureau chief here. I don't make policy. Would I love to be able to offer more services to our neighbors? And that's how I think of everybody who comes into our clinic. You're my neighbor. So I want to do everything I can for my neighbors. Is it logistically possible? Is it operationally a good investment? Those are not questions that I'm empowered to answer. I do know that when we have to refer people out for care, sometimes we lose them because they are coming here, they know they're going to get free service, but there's still a cost, right? There's a cost of time. Sometimes there's a cost of getting the transportation. Sometimes you've got to wait for a friend to do it. Sometimes you got to take time off work. So I know that there is always a cost. Now, if we have to refer people out to a community partner, there's still a cost. There's an additional cost. And we don't know what that cost will be. Maybe the person cannot take any more time off than they took today, and they need to get everything done today. And that's why they don't show up at the places where we refer them to. So that will always be my priority because I'm lucky, that I get to make that my priority. I don't have to balance the logistic, operational, and budgetary concerns.
Thank you. I appreciate that. And can you talk a little bit about the relationship between the St. Louis City and county health departments around this topic, if there is one?
Oh yeah, there's a big one. We always invite the county in to our Pride booth, for example. The county is always willing to support us with clinical endeavors. We meet each other regularly about other issues. Right now, we have a joint work group for a different problem, which is congenital syphilis. And so I meet with my counterparts over there once a month or so. So I would consider us having a good relationship. Does that answer the question, or is there?
Yeah, it does. It's just such an interesting thing. We've got these two health departments in the very, there's more than that, obviously, but St. Louis County, St. Louis City, and some of the services that are provided are different. Some are very complementary. Some are the same. So it's always interesting to hear how we, how the various departments work with the county to best use the resources that everyone has so the most good can happen. Because you're absolutely right that, people are going back and forth. This is not, we're not that big of an area.
Right.
Okay, well, thank you so much for your time and everything you presented today. I appreciate you answering my questions as well.
It was a pleasure and an honor.
Okay. Alderwoman Saunier.
Thank you, Chairwoman Boyd. I had a question just in connection to these numbers and all of this going on. Is there any relationship, or are you all talking about like potentially talking to the schools? Like what type of, is there any type of education or awareness or information shared to like families or students that are in our city that are, young students either in SLPS or other schools?
Thank you for that question. We are working to make sure that we can tailor our presentations for an abstinence forward philosophy, because it is difficult for parents, necessarily school administrators, to endorse sexual health for minors. And we want to approach that conversation with a great deal of thoughtfulness, consideration for the feelings of parents, and the potential for tension created between faculty and administrators who trust us to give good education and their student body's parents. So we are working with SLPS to find out if there's a way that we can present this information that respects the abstinence philosophy, while at the same time providing especially the middle school and high school students with the information that they need to understand that if they're going to make certain choices, here are the potential risks of those choices. Here's what would prevent the risks of those choices. And here is why you should, have transparency with your parents and healthcare provider. Those are all things that dance around the subject of autonomy and respecting that parental authority. And so that is a non-answer, Alderwoman, and I'm very
No,
sorry.
I think,
We're
no, that's
working on
okay.
it,
I was
but-
on the school board, so I know what their current policies are. So what I hear you
Yeah.
saying is you try to figure out a way to give this type of education without necessarily going against a abstinence framework.
In the long run, particularly with our Black families, we want to respect every parent, and we want to demonstrate that we know we have to earn trust. We need to be aware and considerate of religious or philosophical differences. And we need to be sure that students are not hearing, go have sex, here's a condom, So it is and we are currently working on it, because we were originally told it's probably not a go, because we are in SLPS schools, we are presenting abstinence only education. And so I've wrestled with this problem a lot. I know what the teen pregnancy rates are, not off the top of my head, but I know what they
Yeah,
are.
also
And
teen
so-
STD rates.
Yeah, so yes, especially among young women. And we know that a lot of that, I won't say a lot of that, but in our older range of that youth population from 14 to 24, we know that some of it has to do with the rate of drug use, of substance abuse, and folks coming into St. Louis, which is a hub, and bring in whatever from the rural areas, because now we're seeing more STIs in the rural areas.
Mhm.
And we know that that's not a coincidence. So, yeah, these are very difficult conversations to navigate, especially with a community that has zero reason to trust us to have their best interests in mind. So I am absolutely not going to stomp on parental feelings about this, even if we were allowed. We just need to figure out what the best way to get the abstinence forward message across is.
Okay, thank you.
Sorry. Again, I know it's not really a good answer, but it's
No,
the one I
no,
got.
Well, I think it's not that it's not a good answer. I just think the topic is a challenge because and it's ironic, if you're not a mother, you can't relate. And so I had two girls, so I can relate. I with your sons, you automatically, when he turned a certain age, okay, here's some condoms. This is what you need to do. But with girls, it's an education piece. And so you have those dialogues. And so I was one of those point blank mothers. Okay, let's have a conversation, because, feelings are going to happen. So some parents are uncomfortable saying that. They don't know how to present that to their kids. And then a lot of times the kids feel like because mine used to say in your day, well, no, it's the same. Sex is sex. I don't care what day it is. It's the same thing. But you just have to think about choices. And that's how I kind of brought it to my kids. Choices, you have consequences. And so if you make these choices, I not only talked about pregnancy because when my kids were coming up, STDs were very high in our communities. So I'm letting them know. And I used to tease them. I said, you do know they have disease, there's no cure. So I'm like, penicillin doesn't work anymore. So I kind of did a scare tactic, but a reality check to say, this is what's really going on. So I'm proud to say, they didn't get pregnant, they didn't get the disease, but they listened to me and we had honest conversation, but a lot of parents aren't there and they don't know how to present that to their kids. They feel uncomfortable. So
And one of the things, oh, I'm so sorry.
No, go ahead.
One of the things, I mentioned that Black women bear the brunt of oppression, and I feel as if because of the objectification of Black female bodies in popular culture, the idea that your daughter would be someone to be ashamed of or to judge is painful, I would think. I know
Right.
it was for me with my daughter, and that's coming from a place of privilege. So historically speaking, we are dealing with it is difficult to walk that line between respecting that trauma. When you think about it, that's what it really is. Even if
Right.
they knew how to have that conversation, I have had parents tell me, I don't even want to put the idea in her head. And I cannot sit there and argue with a mother who is genuinely afraid for her daughter, because
Right.
that's what it is. She's afraid for her. She doesn't want her labeled. She doesn't want to add to the stigma and shame and the objectification of her daughter. She doesn't, want to police her any more than she's already had to throughout that child's life.
Right.
The things she wears, the way she carries herself, the people she talks to. So it deserves careful consideration. The parents deserve our respect, and we are required to earn their trust.
Right. And I think it's a lot of aspects that cause this to happen. The videos, the records, the crowd that people are in. And so I guess my thing is maybe not so much the kid, we probably need to look at educating the parent, how they can have the dialogue. What do you think will open the conversation for you to feel comfortable enough to start this dialogue? And so now, like I said, back in the day, it was STDs.
Mhm.
Then I remember when AIDS was like devastating, it was killing people to no end. And so it was all about education. And so I'm just trying to figure out how the health department, as Alderwoman Schweitzer said, county and city can be more vocal in regards to educating our youth to make them feel comfortable enough. Because it used to be a time, and I think it still is, youth could go to the clinic and they could, is it for pregnancy, get tested for pregnancy, and the parents didn't have to know. So they could try to figure out how to deal with this. Then the clinic will work with them to say, okay, now we can talk to your parent. But I don't know if that's still that piece in place for those kids. And so I just think our kids don't understand. And then another thing, I think people never are knowledgeable about, and me coming from the long-term care atmosphere, seniors are getting this more than people think.
Yes.
They're in these nursing homes, these long-term care facilities, senior buildings, they're getting the STDs, HIV, this stuff is popping up, and people like, how are they getting this? And they're in these places. That's because daddy go out and play with whoever, comes back, and messes with mama and they give it to her. She's sitting there, but she's only exposed to him. And so he's bringing it in. So it's you gave us a lot of good information, but I think education and empowering is the most best practice we can go with.
And our plan for that to reach the parents and even some of the kids, in 2022, we had 3 people for the entire HIV and STI prevention section, a team that is usually about 10 to 15 strong. The pandemic decimated the public health workforce, and then we are competing with 2 very large, very well-known research universities, as well as a number of nonprofit organizations that really truly live and breathe health equity and public health. So competing for those people became really difficult, and it kept me awake at night. So now in 2024, we finally have a full team. We are a little bit short, because we want to be aware of budgetary constraints and because, we had 2 more positions to fill. But what we can do with this team that we have right now is leaps beyond what we could have done a couple years ago. So increasing our presence in the community is number 1, because we could have all the clinical resources in the world, but if people don't trust us, if they don't know us, if they can't put a face and a name together and associate that with the Department of Health, then we're never going to reach them enough to say, listen, here's a conversation that might be difficult to have, but it's valuable and worthwhile to have. And so by increasing our outreach, increasing our presence in the community, and being known and becoming part of the community, I believe we will get ourselves those opportunities.
Okay. So do you all connect with federal clinics?
The FQHCs?
Uh-huh.
Absolutely. Now,
Okay.
the FQHCs, of course, they have a very specific model. They are if you have somebody who has Medicaid and they already have a primary care provider, the FQHCs technically do not see them because according to the CMS, the Centers for Medicaid and Medicare Services, they are required to register patients in order to treat them. So if they already had that primary care provider assigned to them by Medicaid, they're not actually eligible. And our FQHCs are so invested in being out in the community and in finding ways to expand that reach that they will refer people to us and we will refer to them. I actually by email, I talk with Dr. Tepe from Affinia every now and then about problems I'm having, like where can we have folks go for a rabies vaccine? Because insurance often doesn't cover it. That represents a huge financial burden to folks. The emergency room will give it to them. But first of all, that's not really an appropriate use in the emergency room. And secondly, the patient has to wait anywhere from, 4 to 12 hours to be seen, depending on the level of the triage. So we're looking for solutions together with anybody in the community who will partner with us.
Okay. All right. You had good information and I hope it helped panel, the committee, for them to understand, how serious this is in our community. And so it's pretty much, I feel HIV is like blood pressure. It's a silent killer. Mm-hmm. And so if you don't get it treated, you will, leave this world. And so I don't think, if you've never seen anybody die from this and what they suffer with, it's very unbearable to see how they suffer and how it attacks their bodies. And so you're correct. It was a myth. It was only for men that were, inducing in sex, but now it's all over. And people think prostitution has left. Prostitution has not left. And so that plays a big role in our community. And I feel strongly that as this committee, we really need to support you all to help get it out there more, to get people engaged. ironically, we in our office, we have a container for condoms, and you'd be surprised how quick they left. People were coming through and they were like, what are these? And we were like, kind of, oh, okay, can I get some? So people are really taking them. And so
You need more?
yes, yes,
Okay.
I do. Yeah, I had called and said, I need more of these. So that's a good thing to me. I'd rather for them to have them and use them than not have them at all. So on that note, does anybody else have any questions or comments?
Or need condoms?
I don't have any questions. I just wanted to thank you for coming and giving your presentation, and even your sensitivity between mistrust in the Black community and, health government entities. And just second, kind of what Alderwoman Boyd said, I think that whenever you're navigating those conversations and talking to the district, however you can figure out how to bring the parents along in that conversation is really crucial. I'm not, a mother, but I do have a mom who I think did an extraordinary job at making sure it was always a place where we could have conversations, where we could talk, where we could have dialogue, where there wasn't any shame, just education. And I actually think that led to me making a lot more responsible choices than some of my counterparts. And so I think however you can involve the school districts, the parents in that conversation would be beneficial when you all get there.
Thank you.
Thanks. I'd like to just echo Alderman Saulnier's points, and also just say I appreciate the way you approach your work. I'm feel like people like you and Dr. Mahdi, who bring such positivity and sensitivity and just openness to it, are really impressive. I don't think I could do what you do, and so I just want to say thank you. It's a really important job and really important work. So thank you so much.
Thank you. I tell my team, and sometimes I tell interns and prospective graduates, which may be why I don't get invited back. Don't do what you love, because that will often have the effect of ruining your love for it. Do what makes you angry. Find what makes you angry and find what you want to fix with that anger. And I am fueled. I'm fueled by that anger to address the wrong, to create equity for all people. And equity means you give extra where it needs to be given. So thank you for having me. Thank you for your support. It was, again, an honor and a pleasure to be here. And if you like, I will drop the call so you can get back to committee business.
1 minute. Alderman Balmer, did you have anything?
Oh, no, being the only male on the panel, I'm very respectfully sitting back and listening.
Well, no, your viewpoint is just as valid and important. How do you talk to your sons, for example?
I don't have you. We're never blessed with children.
I'm so sorry.
But it's okay.
You did not say never blessed. Yeah, it's a challenge.
I've been running a tavern for 35 years, so I'm very well aware of all these situations.
Wonderful. I am relatively new to St. Louis, so I don't know which ones they are, but we would love to get condoms into those places. We used to go to, my understanding is that we used to go to clubs and also just do the stroll where the sex workers were. And I honestly believe that doing those things, being back out there, working with people is how we're going to reverse this.
Right. And so do you have a rate for high school students in regards to this?
In regards to
With STDs and HIV?
I cannot break it down by high school students. We work with a range, and we try to be very, so for example, the state will suppress small numbers. If you have only a few people in a given demographic or a given locality, they will suppress those numbers because of the sensitivity toward people figuring out who might be involved. So that would be difficult. I can get you ranges, and that's what I'm planning to do when I send you an email.
Okay, thank you.
My pleasure.
All right, thank you so much, Susan. Tell Dr. Mahdi thank you, and you gave us great information, and we appreciate you. All right, we don't have any resolutions for review, no commit, do we have any committee discussions? Anybody have anything they want to comment on? Okay. We had any, Madam Clerk, do we have any written testimonies?
No, ma'am.
Okay, all right, and so any announcements? Oh, this is a good crew. Everybody's just ready quiet. We'll excuse Alderwoman Tyus for her absence, and I'll call for a motion to adjourn the meeting.
So
So
moved.
Second.
Second, previous roll.
Have a good day.
All right, bye-bye.